Hello and welcome. You've found the Social Work Podcast. My name's Jonathan Singer, and I'll be your host as we explore all things social work. Hey there, podcast listeners. Today's episode of the Social Work Podcast is about Medicaid. That's right, Medicaid. Before you switch over to one of my competitors' podcasts, PodSox, In Social Work, the Social World Podcast. They're not really my competitors. I was just kidding about that. I get it. You don't like it, or you don't know much about it. I'm right there with you. In the mid-90s, when I worked in Texas, I was part of the first managed care Medicaid pilot project. My clients could sign up to have one of 3 managed care Medicaid programs, and they could switch their child's Medicaid once a month. Now, I get it. Patient rights advocates said folks need to have a choice in their provider. Just because they're, quote-unquote, poor doesn't mean that they shouldn't have the same rights that everybody else does. That's fantastic. But what that meant was that I was working with families where there were 3 kids, and each kid was on a different managed care Medicaid, and each month those kids got changed. And so if you provide a service and you bill to Blue Cross Blue Shield managed care Medicaid, but they switched to Foundation yesterday, you can't bill for those services. The terror in our agency was committing Medicaid fraud unintentionally. So the last thing I want to do is to make you suffer through an hour's worth of conversation about time studies, Byzantine billing rules, bureaucratic black holes. I don't want to do that to you, in part because I have been there. But here's the thing. Medicaid has been described as the most important program that Americans know nothing about. Now, why might this be? Well, first off, it's a $450 billion a year insurance program. And last year, it covered 72 million Americans. 72 million is twice the population of Canada. And it's more than the populations of the UK, Italy, Germany, and France. So this is an enormous program. The other reason why I wanted to bring this to you is because there are a bunch of changes that are going on in the way Medicaid works and its role in the United States healthcare, particularly after the passage of the Affordable Care Act. Now, I don't know much about Medicaid, and so I decided to go to somebody who does. My guest for today's episode is Matt Salo. He's the executive director of the National Association of Medicaid Directors. Matt's been there since 2011. He got the job because he was doing healthcare policy for the National Governors Association for many years. He got the job at the National Governors Association because he took a job at the National Association of Medicaid Directors in order to get out of substitute teaching in Alexandria, Virginia. If you want to hear more about that story, wait until the end of the podcast. After I say my goodbye, with the whole klezmer music, keep up the good work, all that business. Hang out, wait. I got a little clip where Matt talks about his job timeline. And there's an Easter egg in there. And I'll just leave it at that. So in today's episode, Matt starts out by just describing briefly what his role is in the National Association of Medicaid Directors, what that trade group does for Medicaid. But then we quickly get into what I think was a fascinating conversation about hepatitis C and the ethical dilemma of, for the first time, having a cure for this awful, awful disease that afflicts a highly stigmatized group, intravenous drug users, as well as folks who receive blood transfusions before 1992. So there's a cure for Hep C, but it's incredibly expensive. And the folks that are most likely to be in need of that are also most likely to not be covered by somebody else's insurance program. And so what does Medicaid do? Well, we talk about that. And then from there, we talk about how Medicaid is changing the way healthcare is conceptualized. He throws out some really fascinating examples about how individuals intersect with physical and mental health care, and how all of that can come together in an integrative behavioral health context. And because Medicaid is such a huge program, and it really affects the lives of so many of the folks that social workers work with, I'm really interested in your feedback. What do you think about what Matt's talking about? So head over to Twitter and tweet something about your experience with hashtag Medicaid, or go to Facebook to the Social Work Podcast fan page and leave a comment underneath the post where I've posted about this episode. So, without further ado, on to episode 88 of the Social Work Podcast, Medicaid and the Future of Healthcare in the United States, an interview with Matt Salo. So Matt, what do you do at the National Association of Medicaid Directors?
So essentially, we work to serve the individuals in each of the states and territories who run the Medicaid program. And whatever it is that they need, whether it's trying to build up a certain program, trying to figure out the best way to maximize their resources, or whether they need to come together to find consensus on an issue to push for a federal change, we're there to help them.
I would imagine that since Medicaid is a state-by-state program, and it's set up that way so that states can individualize sort of whatever it is that their state needs, that it's hard to get consensus among all 50 states.
Consensus doesn't necessarily come easy, and I think, if you look at the big picture of it, then yeah, you will see that Texas and California and Maine and Nebraska are all very, very different. But the beauty of it, and the thing that really makes my job a pleasure, is that when you peel away the big picture politics, the jobs are essentially the same, and the common thread that unites them all is a shared sense of mission. And that mission is to provide the best possible health care to the people who rely on the program within a very, very constrained budget. And when you look at it that way, it is actually remarkably easy to find consensus.
Why does a constrained budget and vast need make it easy to reach consensus?
Well, the twin problems of not enough money and more need essentially forces my members, the states, into a day-to-day decision-making process where ultimately they're going to have to tell somebody no. There's never enough money to do all the things that everybody wants.
What's an example of something that people want that Medicaid just can't do?
So one of the issues that we're facing right now that's gotten a lot of headlines is we have a very, very exciting cure for a major public health scourge, hepatitis C. A new cure has been developed. It's very, very exciting, but the problem is the cost. The cost of a course of treatment to cure hepatitis C right now runs about $84,000 per treatment at a minimum. And while that might not raise a whole lot of eyebrows just by itself, because Medicaid, almost by definition, takes care of the sickest, the frailest, the most expensive members of American society. When you multiply an $84,000 treatment times 3 million people in this country who have hepatitis C, it is abundantly clear that we simply cannot cure everyone right away. Whatever you're paying in any given year is hopefully going to be cost effective in the short term. And the challenge with hepatitis C is it's a disease, it's a terrible disease, but it's one that takes 20 or 30 years to kind of play out. And so the challenge is, if you budget all of the costs of the cure right up front, it may be budget neutral or may be cost effective over a 30-year window, but nobody we deal with actually works in a 30-year budget window. Whether it's people move from one insurance company to another, or move from one state to another, or just the simple fact that state budgets are annual. It's very, very difficult to try to figure out, how do we do this all built in up front.
And so you're saying that is not just Medicaid, but that is all insurance programs, that they are looking at what's the expense out and what is the savings for whatever budget period we're in.
Right. I think, Medicaid is in many ways very much like private insurance. And in fact, in most states, the actual care is delivered through private managed care companies. So the types of constraints that a lot of people will face in Medicaid are very, very similar to what you'll see in the private sector.
So let's say you're a social worker, which many of the folks who listen to this are social workers. So you're a social worker, your caseload is full of people with Hep C. I would think that as a social worker, I would want to advocate as strongly as possible to make sure that my clients got covered. What can social workers do at that point to advocate for their clients who might not have access to any other form of payment other than Medicaid?
Well, I think this is a great question, and there's certainly a very, very important role for social workers to play, not just in this issue, but broadly in some of the Medicaid reforms and innovations that are happening. And I'd love to get into that in a little bit. But specifically with hepatitis C, social workers really do need to take it very seriously that they are there to advocate on behalf of their clients. And, in general, that's going to mean making sure they get whatever they need, regardless of cost. The challenge for Medicaid is to say, yes, we hear you. We may even agree with you, but literally everyone in the program, all 72 million Americans, whether they have Hep C or HIV/AIDS or need long-term care in a nursing home or have multiple chronic conditions or the nexus of substance abuse and mental health disorders, social workers and other folks are advocating for them as well and trying to get them as the best possible care regardless of cost. And again, that's their job, and that's important. Our role is sort of sometimes has to be that of Dr. No, is that because you can't say yes to everything for everyone, you're going to have to figure out, how do you make priorities? How do you balance immediate needs with long-term goals? And that's a difficult role to play.
So what do you do with something like this? Because it seems, from what you're saying, it's a reasonable dilemma, right? Yeah. On the part of Medicaid, right? We can't afford to pay for everybody to get this treatment. And so it sounds like you're saying we're not going to.
That's right. At least that's the plan. So I think it may help to put things in this context. We, as a society, embrace two mutually exclusive philosophies in this area. One of which is that we are, the shining city on the hill, and that we are the creators, we are the innovators, and the cures and the treatments and the innovations and the breakthroughs in science come from us,
from America.
From America. Yeah. And in large part that is absolutely true. And how do we do that? How do we continue to feed the engine of innovation? Well, we reward and we incentivize innovation. And in large part we do that by letting the company that innovates set the price. And that we've found has been a very good way to continue the pipeline of innovation. And that's great. But in this instance, that philosophy does not go hand in hand with sort of the social work mantra or the public health mission to say, if we have a cure, once we have this innovation, we must give it to everyone who needs it, regardless of the cost. Both of those philosophies are absolutely all well and good taken individually. But put together in this situation with a finite budget, it doesn't work. And in that instance, we as Medicaid find ourselves having to make difficult decisions. So what I would say is to social workers who are working on hepatitis C, or frankly, you can take this for any issue, try to figure out where you're going to have the most purchase in a lobbying effort. So if what you do is say, you know what, we should give this to everybody, and I think that's probably where most people will come along, then the other side of that's going to have to give. And the other side is price. And if everyone's going to have access to this particular drug or any future drug that comes along or any future treatment that comes along, if we're going to say everyone has access to it, we're going to have to say something. We're going to have to do something very differently on the price. And so what I say to people is, we're going to need some kind of federal action on this. And I'm not saying that's going to be federal price controls, because I think that's a pretty inflammatory type of proposal, but it's got to be something. And if we don't put on our big boy britches and say we're going to have to confront the price, then we're going to have to acknowledge that no, not everyone is going to get this. And if we still fail to do that, then what we have are budgets that explode. And my concern is that when state Medicaid budgets explode, in this instance, we won't have an American populace that says, thank you, Medicaid, thank you for curing hepatitis C. They're going to say, hey, wait a minute, this is a government entitlement program run amok and it's time to rein it in. And that is really, really bad for everybody on the program.
So interesting. So you're saying that if the states came together and were like, you know what, it's a moral imperative, we're just going to do this because it's the right thing to do, what would the consequence be?
So I think the consequence really is, so if Medicaid budgets start to explode for this or really for any reason, Medicaid's already a really large part of the state budget.
How much of a state budget might Medicaid be?
The average state budget, Medicaid's probably around 25%.
Wow, 25% of a state?
Of the entire state budget. So in every single state, either Medicaid or K through 12 education are the largest item. And they're one of the two. They're always 1 and 2 in every state. It's a big ticket item. And when a program that big grows at unsustainable rates, then you either have Medicaid cannibalizing other parts of the budget. So K through 12 education starts to drop precipitously, transport infrastructure, higher ed, clearly. Higher ed's been taking a big hit for years because of this. So either something in the current state budget goes, or you're going to have to raise taxes. And I don't know where you guys are, but last I checked, in most states, people are not real keen on raising taxes for any reason.
No, I think some of the stats that I've read are that taxpayers are much more willing to have their taxes raised than politicians are willing to suggest, let's raise taxes.
I think some of the issue comes in where people are generally willing to consider increases in how they're taxed, but only to a couple of extents. One, to which they view the increases benefiting them somehow. I'll raise taxes to pay for more education so my kids can thrive. Or if they think that there isn't a lot of fraud and abuse or inefficiency already in the system. Why should I raise taxes? Couldn't you just do things more efficiently with the money you have? So I think there's still a lot of the latter going on in this country. And in terms of the former, one of the challenges we have in Medicaid is that even though it's the largest insurance program, even though we covered 72 million people, it's still very much an underground thing in people's perceptions.
I think most people are like, oh yeah, Medicaid. Like, I don't actually know anybody who's on Medicaid. Like, I know everybody on Blue Cross Blue Shield, but I don't know anybody on Medicaid. And of course, what you're saying is,
yes, you do. Yes, you do.
You do.
Yeah. Not only do you know a lot of people, but in all likelihood, your parents or your grandparents are. And there's this common misconception that Medicare provides long-term care, nursing home care, home health care for seniors, when in fact it really doesn't. And it's Medicaid that, again, quietly is paying for essentially all the long-term care in this country. And people just don't understand that. But with hepatitis C, part of the challenge is that a lot of folks in the community do face stigma. They face...
You mean the folks with Hep C?
The people suffering from hepatitis C, whether they've gotten it, from IV drug use or whether they've got it from bad blood transfusions, decades ago. There is still, unfortunately, a certain amount of stigma. You read the comment section in any article online on the issue, and half of it is people outraged and trying to shame people and saying, why should we pay for you? You should have,
This is your fault.
This is your fault.
This is what you get.
Yes, this is what you get. Why should I pay for it?
Right.
If you're confronting, Medicaid costs that are being driven as a result of curing hepatitis C, I would fear that there would be a bit of a backlash in terms of the public perception saying, not for that.
So what are some of the factors that influence the decision that these agencies, whether large or on the smaller side, make about what to cover and what not to cover? I mean, we've talked a lot about Hep C, but that that's not clearly the only issue. It's just sort of hot right now. But what are some of the things that influence those decisions? And I guess, to what extent are there personal missions of the folks who've kind of raised up through the ranks and become the directors and been like, I want to see this changed, and so that becomes a focus? Does that happen?
Sure, absolutely, that happens. I think you see a lot of issues that, one of the things with Medicaid is, it's so big and the money is so large, and the program is so large that anytime you want to make significant changes, hopefully changes for the better, but changes nonetheless, it takes a lot of effort. You think about turning a battleship around in a bathtub, a multi-billion-dollar a year program. You go in, you say, I want to do things differently. It takes a lot of work. And part of the challenge is what it looks like in any given state is very complex too. And, one of the things that I've said in the past is, one of the reasons why Medicaid isn't very well understood is because it completely fails the bumper sticker test. How would you describe the program on a bumper sticker? Well, for Medicare, it's healthcare for old people. Okay, we got that. But what is Medicaid? And generally the closest you can come is healthcare for poor people, which is sort of like if you're trying to the six blind men trying to describe the elephant, that's a piece of the elephant, but not all. Medicaid covers some people who are poor, but not all. And Medicaid covers a lot of people who are not poor. And a lot of things that Medicaid does aren't really health care necessarily. A lot of nursing home, long-term care types of things, it's not exactly health care. And so what, Medicaid is, again, it's quietly the largest payer or the largest provider of almost every complex or expensive medical service or specialty or treatment in the country. So we have Medicare, but Medicaid is the largest payer for long-term care. We have state mental health block grants. Medicaid's the largest payer of mental health in this country. We have the Ryan White HIV/AIDS program. Medicaid's the largest payer for HIV/AIDS care, and so on and so on and so on. But the theme there is, if it's expensive, if it's complex, and if nobody else wants to deal with it, Medicaid is doing it.
Wow, that is an enormous role that Medicaid plays. Earlier, you were talking about the role that social workers can play. Can you talk a little bit more about that?
Yeah, so I think it's a very exciting role, and one that hasn't been well appreciated. Part of the problem with Medicaid and part of the problem with the U.S. healthcare system is that, by and large, it's structured around what we call a fee-for-service approach, which generally means that individual providers, physicians, dentists, nurses, what have you, they'll deliver a service to a patient and they'll get paid for it. So if you're a doctor and you provide an MRI to a patient, you get paid for it. If you're a doctor and you provide 500 MRIs, we'll pay for all of them. It's turned healthcare into this machine that produces widgets. It produces widgets of services. And we've gotten away from the fact that, what do we want from healthcare? We want to be healthy. We don't pay anyone to get and to keep people healthy. We do it by proxies. We say, well, there must have been a reason why this person needed an MRI or needed a CAT scan or needed a hip replacement or whatever. So we're going to pay for it. But that never adds up into a holistic, how do we get and keep people healthy? And so what the real exciting part about my job is watching how that is changing in different ways, but changing across the country.
And this is a recent change. And I ask because I remember in the 80s with managed care, there was this idea that, okay, we're going to give you X number of dollars per patient. And I think the idea, correct me if I'm wrong, but I think the idea was, and so therefore you're going to do what you need to do to keep this person healthy within that budget. Did I get that right? And is that similar or different?
Great question. Yes. That is what happened 20, 30 years ago. And the reason that kind of failed is that we didn't go all the way. We didn't do it right. What we did was we went to managed care companies and said, okay, here is a certain amount of money to take care of these patients. Go forward and do good. And we sort of trusted that they would go out and figure out how to keep these people healthy. Well, as it turns out, that didn't really work because this is hard. And when you're looking at an entity, whether that's an insurance company or a hospital or a doctor's office or whatever, they've been doing things the way they've been doing them for years, for decades, for centuries. And doing things very, very differently doesn't come naturally to people. And sort of the basic behavioral economics is that people aren't going to change, especially when healthcare is 17% of the nation's GDP. So this is a pretty big, battleship again. They're not going to change just because someone says it's the right thing to do. Essentially what we found was that they were sort of like teaching to the test. We went to the managed care companies and said, here's X amount of money, take good care of your people. They went out and they figured out how to make a profit within that. And that's what their focus was. What we've learned is you have to trust but verify. And so what's happening now is managed care contracts don't just say, here's the population you have to serve, here's the money you have to do it. They also say, here are the quality improvements that you have to meet or exceed while doing this. Here are the outcomes that we demand. And if you, and we're going to be writing you. We are going to be overseeing and monitoring your day-to-day progress. And if we feel, we Medicaid, if we feel like the patients in your plan are falling through the cracks, we're bringing the hammer down. And it's that combination of, financial motivation along with a very clear, set of expectations. You can't just pay someone and hope you get what you want. You have to clearly articulate what you want and tie that to the money. So that's been kind of, on some level, the revolution in how managed care has changed, I think, fundamentally in the past 20, 30 years. But there's a better way that I kind of talk about it that doesn't really have anything to do with managed care at all. And there's this, the great story that comes out of Arkansas. Arkansas is, it's a state in the South, and it's got a lot of poverty, and it's got a lot of healthcare needs. And they don't have any managed care. And if you look across the entire spectrum of primary care doctors in Arkansas, I think 40% of them are in single-person or two-person offices. So they're spread out throughout the state. They're not organized. They're not collectivized. They don't really care for managed care. Never have, never will.
And is that in part because it's very rural, and so you don't have these metropolises where you have like 300 doctors in a single block area that could be kind of organized in that sense? It's more Lone Ranger.
Yeah, I think that's definitely a big piece of it. There are other factors that are probably unique to Arkansas, but that is a big piece of it. But what's important is that, Arkansas sort of said, hey, we see what's going on, and we want to fix this. And so they went out to every primary care doctor in the state, and they basically just brought with them a pie chart. And on this pie chart, they showed this pie chart to the doctors, and they said, this pie chart is healthcare spending in our state. You're going to see some really big pieces of pie. And you're going to see some really small pieces of pie. See this really big piece, 35%? That's hospitals. You see this other really, really big piece, 30%? That's nursing homes. Where's your piece? You probably can't see it because it's 2%. Why is that? We failed. We're the payers. We created a system that doesn't value you. We're about to change that. And essentially what they pitched on a barnstorming tour of the state was a kind of radical new way in paying for care. So rather than saying, yep, we're going to pay you X amount for every MRI, X amount for every hip replacement, X amount for whatever, they said, we've done this deep data analysis of healthcare spending and trends and broken it out in a million different ways. And we can categorize now every patient who walks through your door. Patient A has asthma. Patient B needs a hip replacement. Patient C has ADD, what have you. We know, based on the millions of dollars worth of research we've done, what these people will spend in the healthcare system if we make no changes.
You mean what Medicaid will spend on these people's needs?
Yes. Yes. So Medicaid can expect to pay $20,000 over the course of the year for the average patient with ADD, or $80,000 for the average patient who needs a hip replacement, or what have you. And so they went to the doctors and they said, we're going to do something different, and you're going to be on the ground floor. When these patients come into your office, we're going to track them over the course of the year. If at the end of the year, turns out that we spent less on them than what our projected trajectory was, we're going to take the delta. We're just going to give you half. You are going to walk away with half of what you saved the healthcare system. And, it kind of took a minute, but then the light bulb went on that they realized that this could effectively double their take-home pay in 3 to 4 years. And their initial inertia, or their initial sort of reluctance to embrace managed care or other types of different payments was focused on this concern that, you know what, as a primary care doctor, I can't control what happens to patients. I have an office. It's got 4 walls. Somebody comes in, they describe their problem, they present a condition, I diagnose them, I provide them a plan of care. They leave the 4 walls, I don't know what they do. Are they following my plan of care? Are they taking the drugs I prescribed them? Are they re-engaging in unhealthy behaviors? I don't know, and I can't control it, so you can't hold me accountable for any of this. But this got them thinking that, you know what? Yeah, you're right. You, the primary care doctor, you don't control what happens to patient A when they leave the office. But there are people who could. So the doctors realized that they needed to build teams. They can be the quarterback, but they build a team. And it's got nurses, and it's got social workers.
Aha, the social workers.
And the team is full of people who are going to be able to have that much more daily contact, who can literally follow the patient home and say, hey, what is this person's living situation like? Are they, living out on a farm where they're, 30 miles from anybody else? Or are they living in a low-income high-rise where they're surrounded by lots of other people, but lots of other poverty and lots of other issues? What are their lives like? And they can monitor, are they exercising? Can they exercise? Are they taking their medications? By empowering social workers and other sort of, extenders, workforce extenders, you're able to go out and have a much more regular, meaningful impact in people's lives in ways that make them trust the healthcare system more, but also empower the individual to taking more charge or responsibility over their own care. Because if people ultimately view healthcare that's something that's being done to them and not something that they're doing for themselves, they're never going to get better. So, it's just one example, but and there was one instance where they followed this old woman home, not in kind of a stalkerish way, but they followed her home, and they were observing her and trying to figure out what her day was like. An 89-year-old woman lived alone at home, and strong and stubborn, but 89, lived alone at home. And one thing they noticed was she had a hot dog for lunch every day. And their first thought was, God, those nitrates can't be good for you. But you know what? They realized she's 89, a hot dog every day has gotten her this far. That's not the problem. What was the problem was the way she was cooking the hot dog, which is the only way she could. On a frying pan, on the stove. And she's 89, she was about 4'10", and that meant it was at eye level. And they looked at that for 30 seconds, and they were like, I know how this story ends. This is a slip, it's a grease fire, it's a grease burn, it's an unfortunate incident that puts her into the ER, ambulance to the ER, maybe a stay, maybe a rehab facility. That's a $30,000 incident, to say nothing of the unnecessary pain and suffering. And they kind of looked at themselves and said, well, what does she need? She needs a microwave oven. And they're like, well, under fee for service, they would have said, well, is Medicaid going to pay for a microwave oven? No. I mean, is there even a code for a microwave oven to put on a form?
90.
No. Yeah, there's maybe an ICD-10, there's a code, but in this scenario, they said, doesn't matter. Get out the petty cash, buy her a microwave oven. We're not billing it to anybody, we're not charging it to anybody. We know $100 that we spend right now on this microwave oven has a certain chance of saving her from a $30,000 incident. And they're going to make that decision every single time. And it's that kind of radically different thinking. It's realizing that, again, health care is not just about medical services. It's about embracing the IOM's social determinants of health.
Institute of Medicine.
Yes. What did I say?
Oh, you said IOM.
Yes.
I was just clarifying.
Sorry. Yes.
The Institute of Medicine.
Yes, thank you.
That's one of the things I do on these episodes. Is I clarify little acronyms.
Yes.
So.
Yes, I use a lot of acronyms. I'm sorry.
So do social workers. It's okay.
Good.
So you're talking about integrative behavioral health, right? You're talking about saying we can't provide physical health care without acknowledging the psychosocial factors that influence it, and that funding streams are increasingly going towards medical providers as kind of the conduits, and that increasingly psychosocial services will be partnered with those. That's sort of the future that you're describing here, right?
Yeah, I think you have to nurture the mind in order to nurture the body. There are so many silos in the funding streams, and that's just such an awful way to go about building a healthcare system. At the federal level, you have the Medicare program, which has its own silo of money and rules and doctors and regulations. You have the Medicaid program, which has its own separate silo. You've got education funding, which is separate. You've got housing at HUD that's separate. At any given state level, again, you've got Medicaid, mental health, public health that are all separate. You've got programs that are run at the state level, programs that are run at the county level. It's a chaotic mess. Now, for people like you and me who are relatively healthy, that's probably fine. We can navigate a system without a whole lot of hassle.
Because there's not many of these systems that we need to navigate right now.
Correct. Right. I mean, we joked earlier about Blue Cross Blue Shield. I'm in Blue Cross Blue Shield. I don't need a whole lot of complex cross-programmatic types of services. But when we think about the people in this country who are the sickest, the frailest, and consequently the most expensive, they're trying to navigate all of those different systems, all of which have different rules, all of which probably have their own eligibility cards. And at the end of the day, we talked earlier about fee for service. as kind of a broken mentality for how to get people healthy. The way that I think about it is, fee for service, we abbreviate that FFS. For these folks who really need it, FFS system stands for fend for self, because that's really what we're asking of the sickest, the frailest, the least able, is to go out there and fend for themselves, to try to figure out, well, what do I need? There is a acute care system, there is a behavioral health system, there is a pharmaceutical system, there is a long-term care system, and they are all separate. And we are not going to win. We are not going to succeed at this healthcare business if we continue to treat it as such.
The system that you've just described sounds a lot like the wraparound services that kind of swept the mental health arena in the late 90s, early 2000s. This idea that rather than families or individuals getting whatever services an agency will provide and having to jump from agency to agency, the funding will be attached to the family. And so the family will then say, we need this, this, and this, and this. And then it's up to the team to make that happen. And if that means one of the things we need is a new washer dryer, that happens also. But rather than the funding attached to the person, you're still saying it is attached to the provider, but the provider now has incentive to go outside of what he or she normally would do in order to make sure that the person was healthy and not going to have unnecessary costs and interventions associated with their care.
Right. No, I think that's exactly right. I think the challenge will come when we take this to scale. The challenge will come in trying to translate all of those ideas that you just articulated that all make perfect sense, and the things I talked about, buying somebody that microwave oven. I've heard other great instances where you had a diabetic who came crashing into the ER at the end of every month, almost like clockwork. And they're trying to figure out what's going on here. He's on medication. Turns out he lived in an apartment where he couldn't pay the electric bill. So what that meant was that his insulin in his fridge, by the end of the month, because it wasn't being kept cold, became inert and useless. So, he was taking his meds as he was supposed to, but because he didn't pay his electric bill, he would end up in the ER every month. The answer there, pay his electric bill. A lot cheaper than paying for a, $20,000 ER visit. So I think the challenge that we face in trying to take this to scale and trying to translate this more broadly, there's several challenges. One is, how do you avoid some of the slippery slopes that will come into play? But also, how do you articulate what you're doing in a way that's going to satisfy the taxpayers who are ultimately footing the bill here? And, I think of, the political hay that was made over the so-called Obama phones.
What's Obama phones?
So there was actually, a government program, I believe was actually started under Bush, to help subsidize cell phone access for low-income individuals. And then it kind of turned into an election kind of campaign issue of kind of demonizing the poor. Look, they're getting phones as handout. They're getting Obama phones, and the government's trying to give people cell phones in order to buy their political loyalty. We're talking here now about Obama microwaves or Obama electric bills or Obama houses. And obviously that's not what they are, but when the public sees a government-funded healthcare program that all of a sudden is paying for things that most people take for granted that this is something you pay for on your own, you do start to lose public support. And, there is, again, the slippery slope of, okay, yeah, for, the $1 million Murray who spends $1 million because he's just in and out of the ER every other day because he's homeless and the ER will feed him and give him a place to sleep. Yeah, it makes perfect sense to give him housing. But what about the $100,000 Murray or the $20,000 Murray? And, at what point do, once you've done this, once you've said to Murray, we've stabilized you with housing, do you ever take it away?
The dilemma that you're describing about the public's reaction is a huge political football hurdle, whatever metaphor you want to use. Does that keep Medicaid from wanting to move forward with this kind of approach where it encourages providers to kind of think outside the box and take a more holistic approach to the health and well-being of the citizens?
Yes and no. It's not going to stop Medicaid from moving forward because we know this is the right thing to do, and this is actually, we're on the cusp of real healthcare reform here. But we're kind of doing it somewhat under the radar, as we have done, a lot of things.
Except for now, because so many people listen to this podcast. It's
going to be a tsunami. But again, I think it may inhibit taking it fully to scale when it becomes quite apparent that this is what's going on. I really do believe that some of the innovations that we're pioneering in Medicaid programs are going to become the standard for the rest of the healthcare system. It's going to become the standard for Medicare. It's going to become the standard for commercial insurance. So the extent to which the rest of so-called mainstream healthcare looks on this, realizes it really does work, and embraces it, that gives us a lot of cover. But part of the challenge is, as I said earlier, Medicaid, almost by definition or by default, is covering all of the sickest, the frailest, the most expensive, the most complex, because everybody else has just bailed on them. So to what extent will commercial insurance need to deal with this? Because anyone who actually needs this, they've already sloughed off onto Medicaid's lap anyway.
Right. You and I don't need this.
Exactly.
Yes.
So that's the long-term challenge. Is this? Can we maintain this?
I've never thought about it, but the way you're describing Medicaid, it sounds like the way we describe social workers, right? The people that nobody else wants to work with, right? That's who social workers work with.
Yeah.
Whether it's in a hospital setting or anywhere else.
That's right. Yeah, social workers clearly have a much more hands-on, intensive relationship. But the mission of Medicaid is, I think, very much the same.
Well, Matt.
Well, Jonathan.
Thanks so much for talking to us about Medicaid.
We can talk about Medicaid at my kitchen table anytime you like.
That's fantastic. I really appreciate it. And hopefully we can continue this conversation in the future.
I'd love to. Anytime.
I'm Jonathan Singer, and thanks for being with me today for another episode of the Social Work Podcast. If you missed an episode or have suggestions for future episodes, please visit socialworkpodcast.com. If you'd like to support the podcast, please visit our online store at cafepress.com/swpodcast. To all the social workers out there, keep up the good work. We'll see you next time at the Social Work Podcast. Okay, are you still there? So this next bit, Matt talks a little bit about how he got the job at the National Association of Medicaid Directors. And there's a little bit of a hint as to how he and I know each other. So if you figure it out, go to the Social Work Podcast page and answer the poll. Thanks. This is just kind of a background, but you were the healthcare director at the National Governors Association, right?
Correct. Yes.
So is that how you got to know the Medicaid directors, or is that how did you get this job?
So actually, the ironic thing is I got my job with the governors because I knew the Medicaid directors.
What?
So my first real job, I'm not going to count substitute teaching.
No, substitute teaching is a real job,
Sure,
Matt.
Sure. I did that for a year and a half. I loved it, but it didn't pay benefits. My first real job out of college was working for the Medicaid Directors Association, because spending a year substitute teaching had eliminated whatever amount of money I had in the bank, and I actually ran into a classmate of ours from high school, and who had said, "Oh yeah, no, I'm working at this association, and I think we're hiring. You should come in and apply."
Who was that?
Gina Lasasso.
Gina Lasasso was working there?
Yeah.
I had no idea.
Yeah, there was this. It was an organization called the American Public Welfare Association, which since changed its name to the American Public Human Services Association. And that group represented all of the state Medicaid and welfare agencies. So the state Medicaid directors, the state then AFDC, now TANF directors, the food stamp directors, child welfare, et cetera, et cetera.
Because this was in 93, 94.
This was 94, yep. And I started working with Gina for the group that represented the state Medicaid directors. And I did that for 5 years. And started having a lot of interactions with the governors because Medicaid's 25% of their budget, and they wanted to know, what do Medicaid directors think? How can Medicaid directors fix this? And so I kind of became a liaison to them. And so when their healthcare person left, she, as she was leaving, she said, Medicaid, you should come do my job. So knowing the Medicaid directors got me into NGA. Watching the executive director of NGA walk the political, policy, and logistical tightrope for 12 years taught me how to run an association. So I kind of came full circle.
Wow.
In a prodigal son sort of way.
Yeah. Wow, that's really cool. I had no idea.